This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thanks. And thanks for the invite to come and speak today. I'm going to talk about our implementation at Northern Health and implementing a system in the emergency department. I'm going to just go a bit about the history, and Julie gave you a little bit about that, but I'm going to talk in a little bit more detail. I'm going to talk about our criteria. So what were our criteria in 2009-10 when we decided to embark on this, and what are our criteria today and how are they different? What's the current state for us? What are our audit results showing us, and what are our next steps? So firstly, with the history, it's important for us, what was the catalyst for change? Why did we put ourselves out there and say, as an ED, we wanted to put a system in that recognised clinical deterioration back in 2010? Well, for us, it was we had 2 coroner's cases, and we were identified as being contributing to 2 patient deaths. We had beautifully documented the demise of one particular patient, and contributing to that was the junior nurse who reported to the junior doctor for hours and hours and hours, and they increased the frequency of observations, but there was no intervention. And so that was really the catalyst for the team to come together and talk about what we could do differently in this space. As Chris talked about, being an ED, we do have triage and our triage score to consider, and so where does our instability criteria, as it was known then, fit with triage? We took the view that if the patient was within their triage time, it's an escalation of their triage category and reassessment by senior staff in that space. If they're outside their triage time, then in fact it is a clinical instability criteria. Our process was that the nurse did the observations, and as Julie said, they wrote it on a line on a chart. They recognised the numbers as being abnormal, and then what they did was they go and went to find the emergency physician who in charge and tell them that the patient had an abnormal criteria, met CIC. From there, they stuck a sticker in the book so we could audit it. We had paediatric and adult criteria, and as most EDs, we had lots of posters on the wall to remind us about what the numbers were, because depending on which cubicle you're in was which set of numbers you needed to know. We had an implementation team, and it was pretty standard. We had champions, we had in-services, and we had audit and feedback. So that was probably one of our biggest learnings, was to continually feed back how we were going throughout the process. In 2011, as Julie said, we went to a single parameter track and trigger chart, and that made a difference to our escalation, and we were recognising our results more frequently. Continued along with the evaluation and audit process and feedback. 2012 was really about mainstreaming and the importance of it becoming part of just the general work that we did. It was about, in orientation, in our clinical feedback with our registrars and our postgraduate students and all of the people who rotate, it was just about this is the way we do our business. So where did we get to at the end of 2012? Well, we decreased unrecognised clinical deterioration by 32.7%. Each aspect had improved recognition of clinical deterioration, and we had made some significant improvements. And at this point, we're feeling pretty happy with ourselves, and we don't make any changes for a couple of years. We get to 2014 and we recognise that something has changed. We've had 3 serious adverse events. Those serious adverse events involved a 20-month-old child, a 68-year-old woman and a 48-year-old man. All of them had criteria on their track and trigger chart documented. What we do an in-depth case review process at Northern that involves safety steps. So you get a team of people who are not involved in the process. You sit down and you look at your systems and processes within the ED, and then you make recommendations. Those recommendations are a bit like your points that you need for your identification at the bank. If it's a low risk, it's 50 points. If it's a medium risk, it's 75 points. And if it's high risk, it's 100 points. How you determine the risk is the likelihood that it would happen again if we did nothing to improve the system. And what we identified were that we had 100 points worth of risk here and we needed to do something significant. We identified that the main failure was the escalation protocol wasn't followed. So like Julie alluded to earlier, we went and found our favourite physician or favourite registrar who was then got called to resus and didn't make it to the patient. We had also patients who, in one case where they didn't pick up the chart, so other failures, clinical handover failures. So we do a handover round with the physician at the end of the shift. That didn't actually protect the patient because whilst they were in criteria, they skipped over the picking up of the chart. So there were a number of failures there. But basically at the end of the day, our escalation protocol wasn't followed, and so we made a change to our EDCIC. So what was our response to change? We made the bold decision at the time to follow the hospital-wide response system. Now, it took us the best part of 2015 to implement this. It was tough going. There were lots of debate. We invited all key stakeholders to the room to have that debate in the room before it got to the patient and the floor where it might impact somebody's response. We developed a two-tier track and trigger chart. We have two streams. We have a stream for the ED patient and we have a stream for the admitted patient borders. At the time, and we have improved since then, but we had patients who spent on average, when they were admitted, about 18 hours in the ED. So under our CIC system, the ED team would respond to their clinical instability during that time, and the parent unit would have no visibility of that until potentially the next ward round on the next day. Now what we have is the home team attend for our inpatient borders, and as does ICU, in the same way they would if they were in a general ward area. So it is no different to our hospital system. For our ED patients who haven't yet been admitted, and also our short stay unit, which is co-located, our emergency physicians respond. But the big difference for us is now we no longer rush them to resus. We manage them in place. So rather than the patient being rushed back to resus and having a whole team approach, we take the approach of bring the team to the patient and manage the patient there. If the patient then needs ICU or further intervention, we do it in a planned way. There's no whipping the trolley out and mowing half the staff down to try and get to resus and arriving there and finding out that our resus bays are full. And for the people who do ED in the room, that would be a familiar scenario. So that's where we got to with that. With paediatrics, it was around the same time we had as the Victor chart was being rolled out in Victoria. We just implemented that. Seems statewide chart, let's implement that. We have two streams as well, but we only have one response team. So we have two streams, basically the ED patients who are waiting admission or waiting transfer. We don't have an ICU, so our patients are transferred out. And we have our admitted paediatric patients who deteriorate. Our general wait for paediatric admissions is around about the 4-hour mark. Where we get stuck is the kid with asthma who we're going to stretch to an hour for puffers before they go to the ward, and they don't quite stretch and they don't quite stretch and they don't quite stretch, and then we have to make a decision because they get tired. We have one team, and that team is made up of ED and the inpatient team. Because when our kids go off, we usually need more hands than what we've got available. And so we just have the one team. So where are we today? Well, we have a two-tier track and trigger for adults and peds. We have an ED response and an inpatient response. We have standardised audit and evaluation, and we feed back to two groups. We feed back to our ED leadership team, and that has our physicians and our senior staff at it, and then the information from there goes back to the discipline meeting. So it goes back to nursing and it goes back to the physician group, and we talk about our results. And we talk about the cases that we did well, and we talk about the ones where we didn't. And the registrars pick those up in training, and then we'll look at those as case studies and present them for discussion. And we also do our standard 9 regular audits as well. Because what we're trying to do now is transition to mainstream and just make it part of the core business of what we do in the ED. As Julie alluded to earlier, and Chris mentioned it as well, we have a standard language, and we also have many people who transition through our ED. We have lots of postgraduate students, we have lots of rotating junior medical staff, and a significant number of pool, bank and casual staff who come into the ED. We need them to understand our criteria, and we need them to understand the response. This was the easiest way for us to do that. So how close or different were our criteria? Well, what we've worked out is that hypertension, ABGs and urine output no longer feature in 2016, because they're pre-met parameters now. But variation to heart rate, blood pressure and oxygen saturation still feature in our MET system. They just changed the parameters slightly. No longer do you need to have a saturation of less than 90 on 10 litres of oxygen. We'll let you just have 4 or more. So our audit results have shown that we have improved our ED pre-MET and MET detection. With our CIC criteria, we used to have 8.4 activations per day. We're now having 18.7 activations per day. Our inpatient borders have improved detection. So even though they were subject to the MET system previously, we weren't always picking them up because it wasn't part of our routine system. And so now we pick up about 8 activations a day. We had code blues that were non-arrest scenarios, so just you needed urgent help right now. They've gone from 10 activations in the pre-implementation phase down to 1 in the post-implementation phase. And we've had a decline in our ICU admits now. Some would say that's activity seasonal variation, but what we know is activity increased by 5% during the evaluation period, and that our acuity went up by 2%. So we saw 2% more Category 1 and 2 patients during that time. So we actually think that it's early intervention that's helped to reduce our ICU admission. So next steps for us, because we're always on the journey for quality, is REACH. So REACH is a family escalation protocol, and we'll be implementing that, including the emergency department, Northern Health wide, in 2016. And we're also going to go and take a look at our pre-met in the ED. We want to, for ED patients, and we just want to really understand is that, given that a majority of our patients are in pre-met when they arrive, are we doing the best by our patients, and is it causing unnecessary noise in our system? So the plan for this year is to really focus on what we can do differently, or if we need to do anything differently in that space. Just some acknowledgements to Julie for leading this work and being part of this work for a long time, and to the directors and the NUMs and the ED education team who've really driven this at Northern Health. I'm presenting their work today on behalf of them, so thank you.